Any family, when a new arrival is coming to the family, they'll be so happy. But if something really happens after birth, they feel so uh, disappointed. Especially when the child is born with a very major anomalies and they are life-threatening, it is very tension moment for the whole family. That is the occasion when the team of doctors can make an early diagnosis and refer to a good center, and the team takes care of this child and restores normalcy in that particular child. Probably we are restoring the happiness for the whole family. This particular male child was delivered in one of the hospitals near Begumpet area, and it was very good. They made a diagnosis that the baby male child was not having anal opening and referred to this nice hospital, which is a tertiary care center for all the newborns and children. When the baby came, we looked for any other associated anomaly. There was every possibility we might have missed it. But when I looked for it, there was absence of even esophagus, part of the esophagus. So the baby cannot swallow even the milk or saliva. If that diagnosis is missed, then probably it would have been disastrous if you attended to only anorectal anomaly. I can show you the slides. To make a diagnosis, a major anomalies in newborns, one needs only common sense and awareness, may not need very high sophisticated investigations. But this goes a long way if you make a proper diagnosis. Slide 6. I wanted to share you how we made a diagnosis in this particular baby, where there is no anal opening here. Normally these cases, in any of the best centers, this we label it as very high absence of anal and rectal opening in this. We do normally make a colostomy in the tummy and then restore the normal anorectum and close the colostomy later. Sometimes we may do in 2 stages only in these particular children. But in this anomaly was handled only in one sitting, that too without opening the abdomen. That is the uniqueness in this. Same baby, when we were examining, we looked for is there any other major problem in this particular child. Then we have found that the esophagus, that is the swallowing pipe or ahar nalam, we call it in Telugu, is missing from this area to up to this. This diagnosis is made with very simple tube. If you pass it from the oral cavity, if it is not going down this size, a little finger size tube, you can make a diagnosis. That's all what is needed. If you take an X-ray, the esophagus is ending somewhere very high, and part of the esophagus will be communicating with the windpipe. That is in the anorectal anomalies, how you make is a very high or low where we can make a diagnosis. Just by simple inverting the baby and taking an X-ray, we can see the distance is very high. This we label it as very high one, which needs a staged approach. If you look at the both X-rays, this child has one major life-threatening like anorectal anomaly or imperforate anus or absence of the anal opening, which needs 2-stage correction. And this child also had esophageal anomaly with part of the esophagus communicating with the trachea. That is the one. When there is a long gap, as you can see here, this is the head end and this is lower end, you can see. This is ending very blindly, and the lower one is somewhere here. The gap is too much. Even these cases, it's difficult to correct them continuity in one stage. Sometimes you may have to go to 2 stages, sometimes you have to bridge this gap between some other alternative things. That is a normal routine. But both the major anomalies addressed or corrected at the same sitting is quite unique and adventurous. That's what we wanted to share. Here, as you can see, this is the upper one already opened. This is the lower esophagus joining the trachea. We are trying to restore the continuity in one sitting. This is the lower one, already the upper one is opened, and then we can see part of the sutures are already over, and the other sutures, if you complete it, this is corrected. Now it's completely corrected here. As you can see in the anorectal, this one, imperforated anus, we didn't even touch the abdomen. From below itself, by a special technique, we identified the one which is ending very blindly and then brought it down to the normal side without damaging the sphincters, and then created a new anorectum here, as good as anybody wants. You can see this. And both the abnormalities has to be attended immediately, as early as possible. And by being aware, one should make a diagnosis, especially in these two things. As you have seen, one is very obvious, you can see opening is not there, you can make a diagnosis. But even in these cases, many people are missed in many centers. The other one is not obvious, we have to look for it, especially the esophagus which is hiding inside the chest. We must look for it and make a diagnosis. And then both the ones have to be operated in different positions. One we keep in a lateral position, one we keep in a straight position in the same setting. And in any developed centers, many developed teaching centers in the world, they try to address these two issues in a different way in multiple stages. And to the best of my knowledge, I don't think it was done in a single sitting, that too without opening the tummy. So we corrected both the abnormalities in one stage, in a single way correction was done. And then baby was kept for about a week for observation in the intensive care unit, another few days just to observe without intensive care there. And then we made sure child goes home, how the child is behaving in the house also with the children, with the parents. Now the baby is able to take mother's milk. As you have seen, you were made to wait before taking the photographs. And then baby is passing normal stools, and parents were immensely happy. The disappointment when they got a child with an anomaly, with a good teamwork, we could to some extent rectify it, and they are feeling comfortable. And these unique adventurous surgeries is not the surgeon's credit alone. There is a backup post-operative intensive care unit and then anesthetic services, which plays much more major role in saving these children. We can do these rare innovative surgeries in a setup where there is state-of-art equipment and a committed intensive care teamwork. With the combination of these things, we feel that we will be able to handle any difficult situation and make the parents in a happy way. And of course, all these things we do in the majority of the cases, but we need the blessings of the God Almighty, without which we can't do. However good, however perfect we are, is not possible. In this institute, we are very comfortable and confident to go ahead in handling these situations. It's a really tertiary care institute. The idea of our sharing with you all these views is so that much more people can get benefited and public will be aware of this situation where anything can be handled provided it is planned in a way. I must thank and grateful to my anesthesia colleague Dr. Prabhavati and neonatology team, Dr. Umaraju and her colleagues, and most important, the ambience, high technology, state-of-art equipment is provided by my good friend and CEO of this institute, Dr. Padma Reddy. Without any of these things anywhere compromised, I don't think I will be able to venture such adventures. I must thank you all for coming here to share this moment. Namaste.